So good evening and thank you for joining us yet again for another conversation with FLON. But as all of you know, it's not really a conversation with FLON. It's more FLON talking to experts who answer your questions. We've looked at your questions, we've given them to the experts, and they will be answered. And we are exceptionally honored to have all of these doctors here with us. We know these are the busiest people right now. So for them to take their time and come and have discussions to educate the public, I'm extremely grateful for. So I'll start with the introductions quickly. We've got to my right, Dr. Ellison, who's a cardiologist. And then I've got Dr. Dashirwa, who is a neurologist. Dr. Kashitai, who's a specialist physician. I've got Dr. Titus, who is a medical officer at State and who's also a long COVID survivor. And then I've got Dr. Amrulu, who is a medical superintendent at Karatura Hospital, and she's also a obstetrician and gynecologist. We're laughing because I was saying I'm going to hash obstetrician, but apparently I can get it right. So we're going to get straight into the discussion. And before we go on to long COVID, there is a question that has been burning a lot of people, and we're seeing it. We even saw it on the front page of today's one of today's daily newspapers, where they were speaking about traditional leaders losing their lives to COVID. We're hearing the same about religious leaders. We also know that there's speculation in certain communities, one being the Ovaherero community, a second one being the colored community, that there are certain people more predisposed to COVID fatalities. Now, for everything that we speculate on, there's a medical reason. And that's why we have specialists here to take us through the medical reasons, because I don't think the science is saying there's an ethnic predisposition to COVID. So it's going to be great to have Dr. Kashitai to start off answering that question. Are there people more predisposed? What are the medical reasons for what people are starting to speculate that there are specific groups?
Thank you, Madam First Lady. The first thing is actually that we need to, in order to answer a question like that, we need to look at the data. What does the data show us at? Because we're collecting data every time, when, especially with case management, where I'm actually saving on the National COVID Task Force. Our data are not really pointing to a specific tribal group or specific individual being specifically pre-exposed to the extent of actually being much more vulnerable in that extent. It's rather pointing, the data which we are having is actually that they are pointing to certain clusters of individuals. And those certain clusters have got specific characteristics. They are either in specific professions like ours, healthcare professionals. We have actually had data which is now clearly showing that a lot of healthcare professionals are picking up COVID more than anyone else. And they're also obviously ending up in hospitals more than anyone else. And in terms of the numbers, they're also among those who are also dying from COVID. But we also need to look, and this is just the mere fact that they are actually heavily exposed. They come in contact with individuals. If you can imagine certain colleagues of us spending the whole day in an intensive care unit, which is full of patients who are having active COVID. So that is the one thing. That is that cluster. And another cluster of individuals are actually individuals who are actually working in certain sectors, like, for instance, in the banking sector, where, and the main reason is actually that in the banking and in the mining sectors, where they are actually working in very close confined environments. And those close confined environments are actually creating a better breeding ground for COVID. We all talk about COVID being spread by droplets. We by now, every one of us actually knows that COVID is actually everywhere in the community. I mean, at the beginning we're talking about sporadic infections, but now it's actually a community thing. So people don't really know where do they pick it up. And that's the same thing. I mean, people, for instance, who are working either in the banking sector or similar type of situations, they have got contact with different people who are coming from different areas. And since this thing is actually already in the community, they will actually be heavily exposed. And not only that, the fact that that they are finding themselves in close confined environments where they've got to rely on air cons. Those air cons actually make those droplets to spread easier. And that's the same thing with people with, for instance, in church leaders. Church leaders are also much more prone to that because they are in churches. The areas is actually very close, confined. And at the same time, because this thing is in the community, they are exposed to many different people. And that's the same thing. Same thing actually applies to our traditional chiefs. They've got their consultants and the people with them they are talking, and they've got the community which they're actually serving. So they're getting much more exposed to these individuals, and it's also no wonder that they are actually getting there. And then obviously if you look at gatherings such as funerals, it's clearly at funerals people are much more closer. COVID likes it. COVID likes it at a place where there is no social distancing, where there is big numbers of people actually coming together, big numbers of people even singing, being very emotional, screaming. This is basically what actually spreads COVID around. And if we can actually learn that these are the things which are actually contributing to COVID, being in very close, confined areas with big numbers of people gathering together, that these are the things, these are the real conditions which will actually allow COVID to spread. And then the other thing is also that when you go to funerals, you will see there are many people who are actually doing their best now of actually putting up their mask, but are they doing it properly? Most probably more than 60% of them are not doing it properly. Many people in different places, whether it's now in various offices or even at such big gatherings such as funerals, their masks are basically at the mouth. Their nose is still exposed, or many of them are not even wearing it, they're just hanging it around. And when they are sneezing, when they're coughing, and when they're singing, those droplets goes around and they end up being circulated. So it's for you to put it together. Why do we think certain groups are more likely, more vulnerable to get it? Maybe it's the way how they have actually been doing things. We need to rethink our traditional ways of doing things. We know that there are certain cultures which have got specific ways of actually mourning their deaths. And we know that, talking about this specific environment of having close confined environments where there's a big congregation of people coming together, clearly that is not helpful for the situation of COVID. And that must actually, unfortunately, change, because we cannot go on every time, basically from one funeral to another one, ending up losing people and ending up with people who, a week after they have actually been at a funeral service, end up with more infected people, and a few of them actually succumbing from this year. We need to break this circle. And the only way how we can really break it is actually if we can adhere to the simple principles: social distancing, using our mask properly, and then obviously also sanitizing our hands. But last and the least is actually that we are all crying for normality of our lives. We want to get our lives back. Our children are actually fed up with this thing of the school interruptions. Young people who want to finish their degrees are also fed up. They want to finish their degrees so that they can actually go and continue their lifestyles. The only thing thus far which has actually shown to bring all these benefits is actually the vaccinations. We've seen it, what it's actually doing in Europe. Now they are using they are washing European cups, and they are opening their bars, and that is basically that. And they have actually brought down all these restrictions which have actually been placed on us. At the moment, we need to deal with this here because we are among the 10 worst affected countries regarding if it comes to COVID. We're seeing more people dying, we're seeing more infections coming on, and we're seeing an extreme limitation of our lives. If we can all, as Namibians, pull together and go for the thing which has actually been proven to be of benefit with these situations. We don't have time for any experiments. Try this remedy and try this remedy. The remedies which have actually been proven are talking for themselves. You don't really need to go anywhere else to look at what is actually working for COVID.
So I think that's clear. The data is not suggesting that there are people who are more predisposed to COVID fatalities. And I think what Dr. Kashitai is saying, we must all adhere, and all Namibians are vulnerable. Obviously, there are comorbidities, and we'll go into a more detailed discussion about that. So I'm going to hand over to Blanche. We'll be going through the different questions that have been sent to our Facebook and our Twitter accounts.
Doctors. The first question is to Dr. Titus, who is also a COVID survivor, just to tell our viewers what is meant by long COVID and to share your experience.
So, good evening, First Lady and the consultant, and also the nation at large. So, before I suffered from COVID, and before I had long COVID, I was also a medical doctor. Working in a COVID unit with very critical COVID patients. And around last year, after our first wave, we've noticed that there are a few patients that seem to have symptoms of COVID that last a little bit longer than the rest. So basically, long COVID is also known as long haulers. It's also known as post-COVID syndrome, and some of them also refer to it as basically PAC, so post-acute COVID syndrome. And it's basically when you experience COVID symptoms that have started either during your illness or have started after your illness, and it tends to persist for at least longer than 12 weeks. And the symptoms, there's a long list, but they say most commonly it's patients that especially suffer from psychological symptoms, insomnia, anxiety, definitely. Another important symptom that I still experience is what we call brain fog, where you sort of feel like you are forgetting things and you can't concentrate as well as you used to before. And then also experiencing fatigue, or when you are exerting or you are walking around, you are getting tired. And for me, myself, I was pretty healthy, or I considered myself to be a healthy young man up until I had COVID. And I was admitted in hospital and I was very sick. And then post-COVID, what I experienced, one of the most common symptoms that I experienced, it's improving day by day, is definitely getting tired when you walk around. Especially, at first it started walking around maybe short distances, and then it improves gradually, basically. And then another symptom is also that I experience visual problems also post-COVID. And then third one is that I have been pre-diabetic since after my COVID diagnosis as well. So I am still lucky, at least I didn't end up on oxygen for the next 2 or 3 months, but the symptoms is basically endless, and especially the psychological aspect of long COVID, not just for the patient, but also for the community and the relatives that have lost family members. And it's important to know, especially for the public, is that long COVID doesn't discriminate. It doesn't only affect the old people, those who had severe COVID, but also the ones who had mild disease. Yeah.
So the other doctors, maybe to start with Dr. Amagulu, how does it manifest itself, perhaps to explain from a cardiovascular point of view, neurological, and also on the lungs, to be assisted by Dr. Shadirwa?
I think I'll leave that to the cardiologist to answer. That's the specialty.
If I may,
Yeah.
Madam First Lady. First, thanks for having me here. I think what is quite important, and I think the data is emerging. There are a couple of studies that have been conducted, mostly in sort of North America and Europe, looking at the phenomenon of post-COVID syndrome, and also trying to look at the predominant symptoms. And as Dr. Titus mentioned, obviously fatigue being one of them, sleep disturbances, quite a lot of PTSD, and there were numbers that the study showed up to about 30 to 40% of patients will experience some sort of post-traumatic stress disorder as a result of COVID. Neurologically, we know that headache is quite prominent, and either normal headache or even sort of severe migraine type headaches that do not necessarily respond to routine painkillers. And again, the numbers quoted were quite remarkable, up to about 58% in some studies that have shown that up to 6 months patients can experience these atypical headaches.
The brain fog remains a problem, and that is basically a layperson's way of what we could consider sort of cognitive impairment following COVID. And this is precisely, as Dr. Titus mentioned, issues of concentration, memory, and remarkably also psychiatric manifestations. And one study conducted in Italy, for example, showed a risk of about 18%, of up to about 18% of patients having had COVID with new diagnosis of psychiatric disorders, particularly sleep disorders and mood disorders, specifically depression. So, yeah, in terms of the neuropsychiatric manifestations, these are quite prevalent, and the rough and ready number you'd probably want to quote is between 30 and 40% of patients will experience some sort of neuropsychiatric problem over the long term. The data is still emerging, unfortunately, and I suspect that given our more prolonged experience with COVID going on in the next 1 or 2 years, we may see this number either climbing, most likely, and this is a great opportunity for us to actually look at these numbers and actually try and characterize it within our own population, because unfortunately, most of the data we have is actually imported. And as I said, this is a great opportunity for us to look at our own sort of population and characterize that.
Dr. Allison?
Thank you, Madam First Lady. And I think this is a wonderful forum for us to share ideas and to educate people and dispel a lot of myths. But I'd like to just highlight a few aspects pertaining to the cardiovascular system in its broad sense, but more specifically then with the heart. And obviously there is a complex interplay between what happens with the lungs and its impact on the heart as well. But I'd like to maybe just divide it into 3 groups. And the first is the at-risk population. And remember that if you've got comorbidities such as high blood pressure or diabetes, your risk of having very complicated COVID is 10, 15, up to 20% in certain studies. So it's probably mediated through something called your ACE receptors. And we know that people with hypertension and diabetes and smokers as well, so there's coming through to that environmental aspect, put yourselves at risk from that perspective by allowing the virus access into your body. And ACE receptors are particularly represented in the lungs, and that's our weak point in terms of our protective aspect against COVID. So that's the vulnerability aspect. In terms of acute COVID, I think there are 2 areas where the heart is affected. The one is a direct effect of the virus. And I think the most worrying aspect is when the virus affects the heart muscle, a condition that we refer to as myocarditis, and that's when the heart muscle becomes inflamed. And there's certain blood tests that we can do to help diagnose that. But the important presenting feature from a patient point of view is often with chest pain, and often it's not just the heart muscle, but the sac that the heart lies in that becomes inflamed at the same time. And one of the most important clinical features, which you as the general public may be aware of as well, is if your resting heart rate goes up, and I'm not talking about in the setting of say, a fever or when you're anxious or agitated, but if your resting heart rate goes up relative to what you know your resting heart rate is, that should maybe be a concern that there is, together with chest pain, a manifestation of inflammation of the heart muscle. And then the second aspect is COVID induces an inflammatory response from the body. You've heard of cytokine storms, and some people mount an excessive response, and that's mediated by certain proteins. You may have heard of things like tumor necrosis factor and interleukin-6. Some of those are targets for some of our medical therapy. But if inflammatory response is overrepresented, then certain inflammatory processes take place, and they do affect the heart, they do affect the lungs. And that is important in terms of the process that are involved as well as the treatment. And as far as the post-COVID syndrome is concerned, and here we're talking about anywhere from 4 to 12 weeks after the acute manifestations have settled. From a cardiac point of view, shortness of breath may persist. That should be investigated. Not in every instance is it related to a serious condition, but often should be looked at because there are certain things such as clots on the lungs, a pneumonia which may have not been detected, etc., that can result in shortness of breath. Weakness of the heart muscle can also produce that. A persistent cough, and obviously there's an overlap there with the respiratory system. And then what is well described in the long COVID syndrome are things like persistent dizziness. And there's a particular syndrome called, given the acronym POTS, which stands for Postural Orthostatic Tachycardia Syndrome. It may sound like a long string of words, but it basically refers to the fact that with standing up, your heart rate increases disproportionately. And that has been well described in the medical literature. I would implore general practitioners to read a bit about it, because it is a compensatory response of the cardiovascular system to possibly a degree of affecting the part of the nervous system which we can't control, the autonomic nervous system, but more importantly, a state of not having sufficient blood volume. So you're a little bit on the dry side. And if you then give these patients beta blockers, you can actually do them a great disservice. In fact, they often feel terrible by bringing the heart rate down, because that increased heart rate is a compensatory response. And that often improves with time, but it responds to lifestyle measures. Increase your fluid intake, increase your salt intake, graded exercise, and just slowly increasing what we call your vasomotor tone. So with walking again, reconditioning the body, often that heart rate will come down by itself. And then maybe if I can just finish off by, there are well-established guidelines that in fact were published by the American College of Cardiology last year as to when people should resume exercise post-COVID. The last thing someone wants to do is to start jogging again where you may have had some inflammation of the heart muscle. And just as a rule of thumb, if you are asymptomatic, and a lot of us now in this third wave test positive for COVID, if you're asymptomatic, no exercise for 2 weeks after you tested positive. If you have minimal symptoms or mild symptoms, you need to wait 2 weeks after your last symptomatic episode. And that means muscle aches, joint aches, fever. That's being on the safe side 2 weeks after your last symptom. So don't go start exercising if a week ago you had palpitations, so perception of an extra or missed heartbeat, just an awareness of your heart beating. And in the more complicated patient who has landed up in hospital, who's maybe landed up on a ventilator, they certainly need to see their general practitioner and possibly a physician or a cardiologist to do more sophisticated tests. And there are certain screening blood tests that we can do to look for clot breakdown, to look for inflammation of the heart muscle, to see if some of the hormones in the heart have been activated by this virus, which may have impacted on the heart in a more serious manner.
Doctor, just before we move on to the next question, as a follow-up, I just want to know, are the health facilities, Namibian local health facilities, equipped to deal with long COVID?
To tell you the truth, probably not, because we're actually actively scaling up facilities to manage acute COVID. The numbers are so many. We are converting normal wards to create bed space for the high and rising numbers of acute cases. So in fact, cases of long COVID are probably missed, are probably underestimated in terms of how many they are, simply because we're still doing a catch-up in terms of trying to accommodate those that are newly and acutely being infected. So even the follow-up clinics that should be in place for these sort of patients, we would have to do a lot of work in that regard. So maybe a direct response to your answer is possibly not, because we're still in emergency mode in terms of preparing for those that are flooding facilities currently with new infections.
Dr. Shadhira, after taking vaccines and during COVID, many people complain of headaches. So you spoke about brain fog and PTSD. What does COVID do to the brain, and why is this long term?
Yes, well, the headache is almost ubiquitous. It's quite common after a vaccination. I mean, I myself can attest to that. And so one shouldn't be overly concerned, and it's probably on the basis of the activation of the immune system that then causes that initial headache that patients will experience after vaccination. But to try and answer your questions in terms of what COVID actually does to the brain, there are many reports, and there are fancy words that are thrown around, things like encephalitis, and etc., which is basically a fancy word of saying there's inflammation in the brain. And anecdotally, yes, in my practice, I have seen about 3 cases of this, of patients presenting with COVID and the presenting complaint being just inflammation or confusion and funny behavior as a result of the COVID. I must stress that this is a very infrequent presentation, so it's not something that happens a lot with COVID, but it does happen. And on speaking on the sort of post-COVID syndrome, sure, the cognitive impairment is a problem, and I think most survivors of particularly severe COVID will attest to that. It's a big challenge, and the patients just don't feel right. They have difficulty concentrating, and there are many theories as to what causes that. Whether there's a low-grade fever, like inflammation, that also affects the brain at the same time, or whether there's a bit of an overlap between the sort of psychological impact of having had a severe illness, or even the psychological impact of having been hospitalized in an ICU. So, and that can sometimes be quite tricky to sort of tease out, is this more like a psychological problem, or is there maybe just sort of ongoing inflammation within the brain? And there are obviously some useful tools that one can employ to try and differentiate between that. But by and large, that's what we see. And then obviously the isolated cases of inflammation of the peripheral nerves causing a little bit of paralysis. Although, again, in my experience, these are very mild, and patients tend to respond very well to treatment. So, again, not something one should really be too alarmed about.
Just to follow up, is there a specific age group attached to or being more prone to feeling that brain fog?
Not really. There are some studies that pointed towards the 40 to 49 age group, although, again, the data is emerging, and I think it's too early to say definitely that there's a specific age group that is affected. And I think the rough and ready answer would be everybody is generally at risk of developing this at this stage. That's what the data indicates.
Okay. And Dr. Magulu, to be assisted by Dr. Ellison, what are the common myths and misconceptions on long COVID? How can state, private, and individual players counter them, as well as other fake news? I think Dr. Kashitai can also come in there.
I think there are many, and they're probably related to general myths and misconceptions related to COVID in general. But I think specifically for long COVID, patients can misinterpret ongoing symptoms for this is ongoing COVID, but it might be complications that are arising, a pneumonia that is a secondary bacterial pneumonia that could be setting in. It could be a thrombotic event that could be setting in. And I think those misconceptions that I've had COVID and the specialists or the doctors are telling me that symptoms are going to take weeks or months to resolve can keep people back and prevent them from seeking care. And those are things I think that need addressing, that should these symptoms present, should they persist, seek care, get a proper thorough assessment, and the diagnosis of long COVID is appropriately made. Because I think in itself, it's a diagnosis of exclusion. You've got to be able to say, I've excluded these other things for me to be able to say, okay, this is possible complications of acute infection, and it's part of the recovery process. So don't sit at home saying, this is expected, I'm afraid of ending up in Katutura. You know, people have those conceptions. Come, be assessed, and the diagnosis is appropriately made that this is indeed long COVID, these are the expectations, and this is how you can be assisted to recover. Yeah.
Yes, doctor.
Yeah, it's the myths which are going around that is, I think these have cooled a bit down. The way they had these myths of saying that if you are vaccinated, there's some magnetic stuff which is actually being put into your body, and that magnetic stuff have got some sensors or some tools which can actually program you for after a specific period for certain illness, and indeed actually even taking 2 years, you might actually end up actually dying. This statement went for a long time around there. But I mean, obviously, you know, when you're injecting someone with fluid, you need to know that for that stuff to happen there, that a magnet is actually attaching there, you need to have a lot of metallic stuff to stick on that. So a lot of this year didn't really make any sense at all, that things like that can actually get through that. So the same stuff which we're actually using to tag our animals, for instance, or the same stuff where we are using to put in Depo Provera, and I mean sometimes long-acting oral contraceptive devices which we're actually putting in their bodies is actually almost the same type of equivalent which people were using. And that obviously doesn't make any sense. The other one which a lot of people, okay, but this goes a bit more also on vaccinations, that for instance, I mean, or also having issues with, for instance, with COVID as well, is actually that some men are actually thinking that if they get COVID or if they end up with vaccines, they are going to remain impotent, or they are going to struggle with sexual competencies. This is also a very widely distributed type of thing, and you could actually possibly also put it in as a part of the long COVID or whatever it is. They have done researches, they have done studies which have clearly shown that indeed there is no sense in that. Indeed, your potency on the longer run may actually also end up actually improving if you look at that, because we had these discussions in another interview which we had with our health workers as well, and we pulled out the studies which could actually show that there is definitively no component. The main thing is actually that if you had COVID and you thought you recovered, and now all of a sudden after 4 weeks you are developing these symptoms, this can be part of the long COVID which people are actually talking about, but this can also be showing a serious illness such as a pulmonary embolus, a condition which Dr. Allison called myocarditis, or even a stroke can actually hide behind that. So it's actually quite important also to go and seek attention, for someone to go and do a thorough examination. It can also be that it might have been some medication which you have actually taken during the time when you were having COVID. And some of those medications might actually also have long-standing side effects. We know that when we're treating people in our intensive care units, when they survive, having spent 3 weeks, for instance, on a ventilator, on a mechanical ventilation, having been given a lot of drugs to make them not to be aware of their surrounding, the time when they recover, they usually go through a very difficult time. They actually develop a post-traumatic stress syndrome type of illness, where they get very anxious, where they get very depressed, and obviously also then get also clouded as well. So all these possibilities are there. It's not just a given that, oh yes, you are feeling this here, so you have got long COVID. Long COVID needs to be taken very serious for people to make sure that if there is a hidden serious illness which can be treated, that people can actually go for treatment.
Now, Doctor, your response ties in with this question, which is that the concern on people staying away from general checkups. One is mentioned cancer here. Will there not be an increase in long COVID-related problems and explosion of undiscovered cancers and other illnesses which are not being paid attention to now that COVID is being prioritized over others?
You might be true in what you are saying. You know, when as a national COVID response team, when we looked at issues, at that time when we had our first wave, our numbers were very small. We knew these individuals by name. We had run about 30 individuals at the highest peak, and everyone was talking about these people. But now we know that we cannot even name them. We don't even know who's that. We're talking about thousands of individuals, and actually during that time, we look at different scenarios. We had the one scenario where we were still able to where our system was still able to cater for hospitalization and services of normal individuals. I mean, and also with COVID not affecting the normal services. And then we had a situation where we were already at the maximum. We put them in. We use three colors. We use yellow, we use green, and we use red. The green was actually where normal services could still continue. And then where the yellow was when we are coming to a saturation of our services, we are still just barely managing to give our services. And then the red one was actually where we are no longer with our systems, talking about our capacity to deliver health services in terms of the numbers of doctors and nurses, in terms of the numbers of hospital beds, in terms of the oxygen delivery capacity, the things which we need were actually overwhelmed. And we had different responses as well on that. And that's what you are most probably also picking up from outside, that you can no longer just go for elective operations. If you had, for instance, a leg which was actually broken, or you are working school, you cannot just go to the hospital and get that leg now fixed. Or you want to get a plasmatic operation or cosmetic operation, you cannot just go there, because at the moment, any hospital doesn't have the capacity, not even to talk about increasing the risk of actually putting you there. So obviously, in the state sector, we've also closed most of our outpatient services because of this year, because now what we need to have is we need to have every specific healthcare worker to deal with the current situation, because the numbers are actually overwhelming and our facilities are actually overwhelmed. So for sure, this is maybe the trade-off, that you will actually, some people who might have had some cancers, who might have developed some cancers, might actually be delayed to be picked up. And by the time when this COVID wave has actually gone down, let's say 3 months afterwards, the disease might have actually progressed to such a state that they cannot be treated. But unfortunately, these are the gives and takes. At the moment, our focus is actually to deal with this paralyzing illness or sickness which is actually going on, that which is actually crippled, or which is still crippling a lot of sectors of our lives, and we need to deal with it. So there is a specific sacrifice which we are making, and that might be that. But fortunately, if you're looking at the numbers of people with cancers and those things, those numbers are most probably not going to be so much. So the harm is going to be there, but it's not going to be that extensive.
Yes, Dr. Allison.
Yeah, I think that as long as the incumbent acute problems are still taken care of, there will be an opportunity to play catch up going forward. But I mean, it goes to say that patients who still present with acute abdominal pain or bleeding episodes are taken care of. So those will continue to happen in the face of the COVID pandemic. And that's why emergency care facilities continue to function. We are not doing elective procedures to allow staff and to allow our wards to be open up for COVID patients. But there still is that subset of patients who will come in with traumatic episodes, acute appendicitis, patients who are still having babies, etc. So there is an aspect of normal life that will need to be attended to. And I think in terms of the screening programs, from mammography, from doing pap smears, from men going for their prostate examinations, etc., although those can be put on hold for a period of time, there will be a time where we're going to have to say, look, we need to up these screening programs, because it can't be put on hold indefinitely. But saying that, there are certain patients who are currently sitting at home, for instance, with an early diagnosed cancer, and those patients fall into a bit of a grey zone where there will have to be allocations for them to continue receiving their treatment, whether it's from an operation point of view or receiving radiation therapy or chemotherapy, etc., going forward, because those are instances which really can't wait until the third or possibly fourth wave have finished.
This question always comes up, Madam First Lady. It has to do with ivermectin. And again, this person asking, is it effective, and the side effects? So,
yeah. And there's two elements to it. So I think the first element is, what are the treatments? People
Treatment,
are always asking, what are the treatments that are working? Should I be steaming? Should I be drinking? Which pills should I be drinking? And then ivermectin is always there. You're right.
always
Blanche.
there. So maybe Dr. Titus can start with the type of treatment that he got, and then just give advice on what type of treatment is typically given to those experiencing severe diseases, and then other doctors to tackle the ivermectin question?
No, all right, thank you. So I think for the mild diseases, it's mostly supportive therapy. We do give immune boosters. We also give medications for headache, medications for fever, as those are very common symptoms. And then I think also other medications that we give is that for patients experiencing coughing or so forth, we also give them medications to help with that. So it's really supportive in terms of what is the patient's symptoms and how we can assist them with that. But also when it comes to mild and moderate disease is that, especially mild patients who are being treated at home, is the ability for the patient to recognize when they're getting worse. And I think it's important that if you can afford it or if you can borrow a pulse oximeter, it's a small machine where you can check your oxygen saturation. If you can afford to buy it, or if you have one yourself and you can borrow it to a friend, to a neighbor, please do. And then the other important symptom for me personally was that when you start trying to do daily activities and just walking from your bed to the bathroom or from the couch to the toilet and you are out of breath and you're completely tired, I think that's a very dangerous symptom in worsening chest pain, definitely. And then obviously for severe disease, once again, we have our supportive therapy in terms of oxygenation, if the patient needs it, and then escalating as the need increases. So should the patient require assisted ventilation in terms of non-invasive as well as invasive therapy. And then, and then the other important medication is definitely the steroids. I'm sure a lot of people have heard of dexamethasone. We usually give it to our patients with severe COVID requiring oxygen. There are trials that have shown that it helps. And then we also, to some patients, we also offer remdesivir with their consent, definitely. Yeah. And then if you need intubation, if you cannot cope on just normal face mask oxygen and you need to be escalated and you need to be intubated or you need assisted ventilation, then it's basically that we activate ICU type of, or ICU protocol therapy, and we support you in terms of if your blood pressure is too low, we support you with certain drugs. There are patients that go into organ failure because of the COVID, and there are patients that also develop superimposed infections, especially superimposed pneumonia, so we also treat that. And then there have been a few patients that have developed renal failure, so the kidneys don't work very well because of the severe disease. So they might need dialysis. So basically, we put them on a machine where we try to remove the toxins from the body, which is supposed to be the kidney's job, more or less. Yeah.
Just on that point, you spoke about superimposed. Yeah. For a layman out there, what does it mean?
So superimposed, so basically so if we just talk about the lungs, so in simple terms is that when COVID attacks the lungs, and COVID loves the lungs, because personally for me, it started with a cough before I started experiencing loss of smell, loss of taste, and fatigue. So because COVID attacks the lungs, it also makes the lungs vulnerable to be attacked by other bacteria and other viruses. So it just basically means that it's superimposed that on top of having the COVID, you can also get another bacterial pneumonia in the lungs, infection in the lungs. Yeah.
Okay. All right then.
Just a short thing. Dr. Titus, why did you not use ivermectin? You are a well-educated person, you have read it, and you know exactly why I'm asking you that as well. Sorry.
No, good question.
So personally for me is that I haven't really seen the evidence that ivermectin works, and ivermectin is a drug that was designed to sort of kill parasites. And I myself, and I think a lot of people who have access to the internet, and there are quite a lot of patient or public friendly websites on the internet, and I went to read about the side effects of ivermectin. So despite knowing that there's not real evidence that it works and that it might actually make some patients worse, the side effect and the adverse effect profile, for me personally, it scared me, because it can cause liver injury, it can decrease the white cell count in your body. So when it decreases the white cell counts, which are the blood cells that are supposed to help you fight infections. It can also predispose you to getting other infections as well. And then it also has obvious other side effects such as nausea, vomiting, diarrhea. Some people can experience allergic problems as well. So I think it was just mainly the side effect profile and the fact that I didn't find evidence that it worked. Yeah.
Since Dr. Kashitai is also interviewing people, I want to ask him a question as well. Because there are doctors who are recommending ivermectin to their patients. And what do you have to say to those doctors? Because we tend to, we on these forums are telling people, listen to the doctors. Now there are doctors saying this.
You're still dragging me, Madam First Lady, you're still dragging me on the spot. You see, I was praying and hoping that Dr. Dashiro and Dr. Allison will take this question. I know that there were follow-on comments which were made by very prominent people about myself and Dr. Sikuvi making statements about ivermectin. You see, the reality of this disease is actually that there are frontline healthcare workers, there are frontline doctors. There are frontline doctors who are seeing the suffering of these patients. We're sitting there every day with myself and Dr. Sikuvi and a lot of my colleagues here. We are going into the hospitals every day. We are seeing these patients who are coming with severe disease, who are fighting and gasping for air. We're the ones who are giving these people oxygen and making plans to advance them to higher levels of making sure that their lungs are working. It's a terrible feeling to suffocate. And this is all what everyone is actually talking about. We're seeing these people, and we're seeing them to the extent that sometimes we put them to sleep and then we put them on ventilators. It's not a nice thing to be on the ventilators. We are seeing this here. We are talking about experience, what we are getting here. You know, COVID has made us to go at a higher, different level than what we were overnight. It's basically the same thing like when HIV also came in here. There were not many people who knew anything about HIV, but because of the extent what it was actually killing people, the people had to become overnight experts. And we have unfortunately also been put on the front line. We have been having the opportunity to see, to witness and to see what is working and what is not working. Besides the fact that we are serving on national committees which are completely independent, not political, motivated or anything like that, where we're sitting and taking the interests of the nation at heart, and where we are bringing in treatments which are of benefit. There is the pillar where we are actually sitting, which is named the case management pillar, which is actually sitting with standard operational procedures, guidelines, which these guidelines have actually been taken from all the experience, the proven experience worldwide, be it now from Russia, be it now from China, or be it now from the Western world. We are using this here. And we are using guidelines which have actually been accepted by international authorities. Now, what we have so far done is actually that we have been looking at all the information, the drugs, the way how this young gentleman was actually talking about, all this information, the way how he was treated, all the way how he was actually putting it down on the symptomatic treatment. You give them painkillers, you give them, when they're very critical, you give them dexamethasone. I can quote your studies. I can give you names of the studies. I can give you a paper which is actually there. And I can actually tell you that these studies have actually been looked by credible evaluators who can actually say the way how the study was actually conducted was properly. It was not like one study is actually taking people, it's taking people a specific amount of people, but there are no controls, or when they are testing for the one thing to look at the efficacy and the safety, but at the same time they are not controlling it with very clear placebos or whatever it is. It's things like this here. And from the existing evidence, what is actually at the moment there with ivermectin is, it's unfortunate. You can do your best to try to find credible evidence, but you're not getting that. I can quote you, I can tell you actually, recently the largest trial which they use now, recently, I'm talking about it was published in the BMC Infectious Disease Journal it was roundabout dated the 5th July. And the South Americans tend to be using this drug a lot because they believe in that maybe we have got the commonalities that they have also, it's also cattle country. The South Americans, and maybe, you know, when you look at Argentina, when you look at Peru, and when you look at Colombia, all these studies, most of these studies are actually coming from those countries. And when they were conducting this specific study, they had to try to enroll a big number of people. But why? They only managed to get 500 people, 500 volunteers in that type of study. And out of 23,000 individuals, they only managed to do that. And what is the reason? The reason was actually that most of the people, over 12,000 people, were already on, who actually volunteered to participate in that study. They were already on ivermectin. And when they did that, they took these 500 individuals, they put half of them in the one group where they give them ivermectin, and then they take another one, the 500, where they say these are placebo. Obviously, people didn't know what they were getting, and then they were following these individuals up in terms of the adverse effects and in terms of the prevention of hospitalization and the severity of illness. And they look at this, and they look at these individuals. Round about 14 of these individuals who were on ivermectin all ended up in hospital, compared to 20 individuals on the placebo group. So the difference in the numbers were not so big. But what the placebo group had was actually that they had more people who were at risk of developing severe COVID. This was, they had more diabetics, they had more hypertensive patients. And when they followed these individuals up, they realized that 4 of those individuals who were taking ivermectin actually ended up on the ventilator, developing severe respiratory failure and requiring ventilation. And then on the placebo group, they had 3 who actually ended up requiring that. Yes, the ivermectin group only spent 5 days on the ventilator, whereas the people with the placebo had 10 days. But overall, the conclusion of that study was actually that, and this was the biggest up-to-date randomized study which was done on ivermectin. The conclusion was actually that there was no statistically significant study. There was another, significant difference between placebo and ivermectin. In fact, there was no benefits which they could actually see. And then there's another study as well. I can actually talk about the Colombian study which was published. But this is basically that I will leave it
Dr.
at
Ellison
that.
also has a study that he wants to
That-
talk about. in relation to
It was with reference to the Ivacor ivermectin study, but I think just to make a comment about that is, in fact, if you look at it, and I know the numbers were small, but it is one of the first randomized placebo-controlled trials that we've got. You know, all of the data before that are being quoted are based on meta-analyses, and those have got huge statistical flaws. And you know, it amazes me that there are almost a philosophy of vigilantes out there who are advocating the use of ivermectin when we don't have the data. And in fact, if you look at the Ivacor ivermectin study, in fact, the people using ivermectin did worse. So we've now got a study that doesn't just show benefit, it shows that the ivermectin treated group did worse. And you know, this historically, if you look back, this came from an Australian university. They had to give 100 times the dose of ivermectin to get an antiviral effect. We don't know how it works. Does it stimulate our immune system? It's very unlikely that it has a direct antiviral effect. And if you look at international organizations like the World Health Organization or the Center for Disease Control or the National Institute of Health, ivermectin does not feature in any of those trials because there has been that concern. And Medical Protection Society from Southern Africa today issued a statement saying that based on the Ivacor ivermectin study, there is a liability component for doctors who are prescribing ivermectin. As it stands, it's a Section 21 drug, which means that if you're prescribing it, you have to see the patient face to face. You have to explain to them the risk-benefit ratio. And if you're not doing that, then you are, potentially legally liable for the complications that occur. So there is a downside to ivermectin. There's no doubt about it. If I can just go back to one of the aspects, though, that's also very important, is that although we covered a lot of the aspects of treating relatively uncomplicated COVID and the more complicated COVID, there's a vast spectrum of increased risk of clotting. Yeah. And that clotting risk occurs during the acute episode, but it persists for afterwards. I mean, in my own practice, I have unfortunately seen tragic incidents of people having strokes, people having heart attacks, people having clots in the arteries and the veins of their legs, people having clots on their lungs, pulmonary emboli, for 3 to 6 months after COVID infection. So I think what is fundamental is that for uncomplicated COVID, patients should be on an antiplatelet agent, something like aspirin. As soon as they're admitted, they get Clexane, enoxaparin, they get an injection, or possibly Xarelto, which is almost like a tablet equivalent. And the duration of that is very dependent on how sick you are and what other risk factors you've got. But it is a concern that there is a direct viral effect on the blood vessels, but because of the inflammatory response, that prothrombotic risk, that risk of sticky blood, persists afterwards. And I think it also spills over into, if you look at some of the risk of the vaccine, and I will reiterate, it is a tiny risk. I mean, if you look at the risk of clotting on the AstraZeneca vaccine, it's 1 in 250,000. I mean, your risk of getting a clot from COVID itself is probably 16%, and that's a conservative estimate. So, my recommendation, and I do individualize on a patient-to-patient basis, is that if you're at low risk of bleeding, take an aspirin, a mini aspirin, so in the form of Ecotrin 81 milligrams or aspirin CV 100, and use it, I think, for the duration of your vaccination period until you've had your second dose and for a month afterwards.
For that long?
Yeah, I would do that because it's going to minimize your risk.
Yeah.
Certain high-risk individuals are either already on blood thinners or may in certain instances need an escalation to a blood thinner such as rivaroxaban, Xarelto. Yeah. And I think that needs to be discussed with your doctor. But it is a concern to me that the risk, and I can tell you it doesn't feature in any international guidelines, but it is a concern that the risk of clotting persists for quite a while afterwards. And the only other concern which may have come to the fore, and it's more related to the Pfizer vaccine, is that in Americans and in Israelis, a very small subset have developed some inflammation of the heart. It's a minor thing. It has resulted in 2 patients being admitted, no mortality. So it's a very minor complication from a vaccine, but relative to the disease itself, you've got to weigh up in every instance what is the benefit compared to the risk. And individualized.
And I just want to quickly jump in there, and especially with Dr. Marulu, who's a gynecologist as well. So we were given the same advice by the same doctor about blood thinners not exercising, which we've taken, and I'm currently on blood thinners. But I think what I didn't think about, and which I think more awareness should be made for women who still menstruate, the impact of blood thinners. For their next cycle. I think if you can just take that through, because I think a few women are in for shocks when they go into their next cycle and they're on blood thinners.
They can bleed more. That is understood. But again, it's the risk-benefit ratio that you need to weigh. The risk of ending up with a clot in the lungs, which is something that is fatal, acutely fatal, versus the inconvenience of heavy bleeding, and you stop the drug and monitor for a while, and that's one thing. When it comes to pregnancy itself is a hypercoagulable state, simply because your clotting factors go up in preparation for potential childbirth and bleeding. So obviously, when you add COVID to this, and how clotting is a high risk with COVID itself, that clotting is magnified, or that risk is increased in pregnancy. And we are seeing it where COVID in pregnancy tends to be more severe, more critical. We've had quite a substantial mortalities countrywide, I think nationally. And I'll say off the top of my head, probably it should be more than 30 deaths that we've had since the beginning of the
Of
pandemic.
women who are pregnant.
Yes, so even the
That's
issues
right.
of vaccines in pregnancy and in those that are breastfeeding, you've got to weigh that risk-benefit ratio. And I think that the biggest risk is, are you willing to get severe or critical COVID that requires hospitalization with the possibility of mortality by not being vaccinated because of concerns that may be there. The data thus far is telling us that it's safe in pregnancy. Obviously, long-term data in terms of what the effects of these vaccines on the fetus, it's not there simply because this is ongoing. So the pharmacovigilance that is ongoing regarding vaccines and their use, we will still have to go forward and look into that. But for now, I would be recommending my obstetric patients, certainly, and those that are breastfeeding to be vaccinated, because what we are seeing coming through is much worse. You're leaving children orphan, and it's myths and misconceptions and fears that are understandable because the data isn't there to help you be a bit more certain. But what is certainly certain is that you are more likely to end up with severe and critical COVID, which the outcome most of the time in pregnancy is not so great. So my advice is, even for women generally, non-pregnant, please get vaccinated. And obviously the issue of clotting, that can be addressed when it presents, if it presents. I think that's what I would like to say. The other thing was with concerning treatment, I think people shouldn't be afraid to be tested for COVID should they become symptomatic of the different signs and symptoms as discussed. I think knowing early and initiating outpatient treatment early is the key to minimizing hospitalizations, especially with the current state where we're in. So if you are having symptoms, please go and get tested. Know that, okay, I tested positive. Get assessed by a doctor. And if you have to be categorized accordingly, initiate treatment early, because that is what is going to keep you out of hospital. Most people are in denial. They would rather pretend this is flu. I always get flu every winter. That was my mentality too, you know. But know where you stand so that you start treatment early. And you can be managed outside in the outpatient setting and recover. The majority of people will recover, and I think that's the message people need to know. I think most people tend to think, oh, COVID, it's like a death sentence. It's almost like in the early days of HIV, AIDS, and that's the general fear and panic that's going out there. The majority of people will recover. The majority of those that are vaccinated are going to get, should they get COVID, it's going to be mild, and they will recover from this and live to tell the tale. Most of those that are hospitalized, even in the industrialized nations, America, the deaths that are being reported, 99% of them are in unvaccinated people. In our country, it's 98% of those that are dying in our country right now, nationally, are unvaccinated. And I know one of the myths is the Ministry of Health is lying about these statistics. It's actually the ones that are vaccinated that are dying in the facilities. The truth is, they are unvaccinated. If you get those daily status reports, you get vaccinated status of the current 200 admissions, whatever, you know, across the different sites. 1, 3 here, 2. The remaining 98%
Unvaccinated.
are completely unvaccinated.
And what does the unknown status mean? Because there's a question. I saw the Minister of Health answering, but I'd like you to also answer it.
This is those where they either come in critical and there are no family members to substantiate, support the vaccination status of the individual. And it's just, it's not known. That's literally what it is. So there's no one to verify whether or not this patient was indeed vaccinated or not. So it is stated as such. Yeah.
On the question of vaccines, this person is asking, what are the long-term effects of the COVID-19 vaccines, and can I get vaccinated if I have long COVID? I think Dr. Titus can also come in there. So.
The answer will be sweet and short, and maybe yes.
And on the long-term effects? Yes, Dr.
Can I
Kashita.
add something on that?
Yes.
You know, you've heard the unpleasant symptoms which you can get with long COVID, that you need to consult different specialties. You need to go to a cardiologist, and you need to go to a neurologist and a psychiatrist, and maybe a physician, a pulmonologist, and also go and for physiotherapist. A lot of people are actually going to be involved with you. So on the longer run, you may actually end up having so many consultations that you don't even know where to do. Your time might just end up being spent with consultation, consulting this person for this, whatever it is. You see, the best remedy for that is, what is it? You use what is proven to prevent COVID, and for the time being, up to date, what we are looking at the world, the evidence is actually showing itself. If you want to prevent the long COVID syndrome, get yourself vaccinated, because at least you will not going to end up getting COVID and end up being at risk. We've even seen people whose disease was very mild at the beginning. They didn't have any complications at all. They went through the COVID, and they said they don't even understand what other people are going through, talking about pain or whatever it is. They were rather asymptomatic. But among those people who develop post-COVID syndrome 4 weeks after having had COVID are also individuals who had very mild disease. And then they end up with these debilitating symptoms. So the main catchword is actually get yourself vaccinated, because that's the only thing which is actually proven to prevent COVID.
And then there's a question here. Can I get COVID-19 again? Does it matter if I survived having been vaccinated or not? If I can get it again, will it be life-threatening? Dr. Allison.
The short answer of that is yes, you can contract COVID again. One of the challenges we've got is the mutation. So the way the virus responds to its environment is by increasing or changing its spike proteins, and these are the proteins which it uses to get access into the body. And these various mutations have been, according to the Greek alphabet, been given alpha, beta, delta, etc. And we know now in our environment, much like South Africa, especially in Gauteng, that the delta variant or mutation is the predominant one. And although it doesn't seem to be more serious in terms of complications, it does seem to be more transmissible, which means your chance of spreading it to other people is a lot higher. And this is going to be one of the challenges going forward. I mean, the lambda mutation has now, reared its head in countries like Peru, and we will have to watch cautiously whether some of those mutations, in fact, do translate into increased risk of dying. But I think, this is where the vaccination program as a global initiative needs to become more buoyant and to gain a bit of momentum, because, I mean, for a world population of 7.6 billion people, 3.2 billion people are vaccinated at the moment, according to the Johns Hopkins website. Countries such as Israel, where you've got vaccination rates of 60% or above, they've got a 1 per million mortality rate. A 1 per million mortality rate. I wish we had that. But that is the best vaccinated country in the world. Some countries have lagged behind. If you look at Australia and New Zealand, they are floundering at about 4%. And Africa as a continent, 1.2%. We need to do better. We need to improve education. I mean, I heard on our local radio, 50% of people are concerned about being vaccinated. Hopefully tonight we've dispelled some of those myths. I mean, all of us here have been vaccinated. The proof of the pudding is in the eating. We practice what we preach. And the one thing is that remember that there is a bit of a lag phase in terms of developing full immunity. And although, for instance, in some of the vaccines where you need 2 doses, such as the AstraZeneca, your total immunity is not up to its maximum until 2 weeks after your second dose. So there is a period of vulnerability until you are fully vaccinated. But what's important is if you've had previous COVID, and certainly if you have been vaccinated and contract the virus, the risk of getting severe COVID is very, very small. In fact, there are a handful of patients who have had to be admitted and land up on ventilators in that scenario. So vaccination works. There's a lot of data to support that.
Absolutely. And I think that certain points just cannot be sort of emphasized enough. And I mean, think if talking about the long COVID as well, and the emergence thereof, not only does it impact the person itself, but I mean, there are studies looking, I think there was a study I was reading 2 days ago in Italy that looked at absenteeism from work, just as a result of long COVID. Up to 15% of patients who were interviewed or called afterwards were missing from work. This has a massive economic impact on the family, on the society, on the country at large. And so it just makes sense to utilize whatever tools we have to try and minimize the incidence, not just of acute COVID, but also of the post-COVID syndrome with its long-term manifestations. And I think this is something that again, cannot be reiterated strongly enough.
I like that point, because I think we often emphasize vaccines, do it, it's important for you and your health. But we want to get back to normal life again. We want to also be like the Euro Cup, where people are cheering for their teams and living normal lives. And we want to mitigate the financial and economic loss and anxiety that's happening.
I see Dr. Kashita wants to add.
To me, it's just to give numbers to what Dr. Allison was talking about with the Delta virus, because everyone is dead scared of Delta virus at the moment. If you had your first shot of AstraZeneca, your chances of actually getting of preventing symptomatic disease is around about 33%. Symptomatic disease, which will not take you to the hospital. Okay, and if you had your second shot of with that for mild disease, you have got a chance of around about 66% of preventing it. But, and this actually refers to most of the other vaccines which are actually on the market, for severe disease, which will make you to end up in hospital requiring oxygen, ending up on the ventilator, or ending up losing your life. All those vaccines which we have so far thus brought into the country, their percentage of actually preventing severe critical ill disease is basically over 85%. The numbers are actually talking for themselves. But not only that, I mean, since we are all inclined to looking at the Delta is affecting individuals who are not vaccinated much more heavier. Because why? The individuals who are actually vaccinated have given their bodies a chance to be trained how to deal with a virus should the virus come into their bodies. Even if it's a new variant, there are still different mechanisms. It's not just the antibody mechanisms, but also the cellular mechanisms, which will actually defend the body. So if a vaccinated person gets the infection, he's more likely going to keep it with himself and not spread it to someone else. Whereas if you are unvaccinated, that Delta virus is going to multiply and multiply, and you are actually going to become a risk to the other people in your environment. Because if you don't end up in hospital, you're actually going to end up spreading it around.
Yes.
And these are just studies, findings which people have actually gotten. And that's why it's actually much more important for everyone to go now.
Doctors, as health workers, I think this question...
We've already answered that question, Blanche.
No, the question on what happens when health workers don't believe themselves in vaccination.
Oh, in vaccines. Okay.
Yes, and then as a result, this person is saying that's why there's so many confusing messages. So in that case,
yes,
any advice?
You need to look at the people who are taking care of you. You see, the same question is actually that you need to ask yourself, we were talking about severity of disease here. When you're going, the people who are spending time in the hospitals taking care of you. The ones which are, I will even call them the anti-vaccine campaigners or whatever it is. You will not find them in the hospital taking care of you when you have got critical COVID. You will not find them looking after you, taking care of you on the mechanical ventilator, taking care of you, doing their utmost best, sacrificing time to save your life. You're not going to find them. Indeed, the doctors who are actually looking after you are the ones who will actually most probably advise you and beg you to go for vaccines. Because on the longer run, you are actually creating more works for these doctors. These doctors are actually overworked, they're over-demanded. And this is the message which you get from all the healthcare workers. They beg you, they say, please go and do something which is actually being proven to prevent this disease, because we can no longer take it. Doctors, nurses, health professionals are putting their lives on the line for you. They're spending days. Sometimes if I look at my nurses, they're in the various ICU where I go. They come in the morning at 7 o'clock. They hardly got any time to go and even go to the toilet and pee, for that matter. They are put on 6 hours shifted continuously on shifts, continuously on their leg. And then when they are given the time, they're only given 15 minutes to just go and put something in their mouth, and then coming back again. They're exposing themselves. There are so many procedures which we are doing to try to save the individuals who are critically ill. These other colleagues who are outside there, who are actually really putting their lives on that. And the message which they're actually telling people is actually that, please go and get yourself vaccinated, because by doing that, you will actually decrease the number of sick people who we have got to care, because we can no longer take it.
Madam First Lady, we've got about 10 minutes left, so for you to continue the discussion.
So what I would like us to do with those 10 minutes is, I'd like to, so I'm in these discussions, I'm Kelly Rowland, I'm a backup singer. And you guys are Beyoncés, you're the main singers. So I think each one of you, if you could just take 2 minutes to just, what are your strong key messages that are coming out?
I got nervous for a while. I thought you were going to ask me to sing. I think, if we take the HIV analogy, Namibia did so well compared to our neighbors with the HIV rollout. I mean, South Africa's handling of that was diabolical. We need to, as a collective nation, come together. We need to look at the science. We need to dispel the myths. We need to all be vaccinated. The data is there. I've got no problem with it. My patients I'm advocating to them, follow the science, get vaccinated. And I think one of the huge tragedies is that it's almost become use ivermectin or be vaccinated. So we've got this dichotomous misperception out there. And it shouldn't have been like that. We haven't known about ivermectin. I think the more we know about ivermectin, it looks to be more of a problem than a solution. But vaccination, we know, is going to be our saving grace going forward. And just one last thing as well is that this is it's a complicated virus. It affects, we've got a representation here from every possible discipline in medicine.
Yes.
And when we treat a virus like that, we end up on a shopping list of different medications. So we often are giving them a group of antibiotics called macrolides. Macrolides impact on the electrical system of the heart. We are taking multivitamins. We are taking dexamethasone. And all of those drug-drug interactions are, we don't have a huge number of trials looking at that. But this, the textbook on COVID has not been written. We're all learning. We're learning as we see patients at a governmental level, at a medical level. But we need to work together.
Yes.
And I think we need to respect the science that's there. We need to respect the international organizations that are also the safeguarders of that information. And when those are put in place, I think we need to, as medical practitioners, respect that as well. And first, do no harm.
Okay. First, do no harm.
Yes, no, thank you, Madam First Lady. I think from my end, two things. Obviously, as much as we can, I would encourage the community to try and avoid contracting the illness, number one. And there are mechanisms that we've discussed about that. Number two, obviously try and avoid the long-term effects, the so-called post-chronic, post-COVID syndrome. And I think the last point to reiterate is having symptoms, especially having recovered from COVID, it may be useful to take symptoms a little bit seriously, get assessed, do not be afraid, do not shy away from your healthcare practitioner. Make sure, because there are some interventions we can do to improve the quality of life of patients, all right? There are things we can do to help with the anxiety. There are things we can do for the headaches and the insomnia, et cetera, et cetera. So that's a parting word.
Thanks, Dr. Dashira. Dr. Kashitai?
Yeah, just to try to dispel these myths and things like that. When you are investing your money on the money market, what do you call it? The stock exchange, You know, you don't just go blindly on the stock exchange and then dump your money on anything. You do a study of that company on which you are actually investing your money.
Yes.
And then you invest, because you stand a chance of actually losing
Exactly.
everything at all. And when we're talking about COVID, you stand a chance of actually losing your life, you stand a chance of actually losing your loved ones. And you don't want to end up in that situation. You know, we don't have time for speculations and for going around trying to drive whatever agendas we are trying to drive. We leave those agendas somewhere else. Please go and do those agendas elsewhere. Put them somewhere else. At the moment, we need to be serious and deal with people. This is people's lives which are being lost. A lot of people are suffering. We cannot just come and keep on pushing agendas and saying that use this specific treatment because you stand a chance of actually preventing any illness, a severe illness. This will actually take you there. We're seeing individuals who have actually done that. So I'm begging people that they must actually put their money on things which have actually been proven, and that's a vaccination. And they must put their money on those individuals who can actually take them better care of them.
Thank you, Dr. Kashitai. Dr. Titus?
Yeah, so I think for me personally, the first thing I want to talk about is that we are in a very critical time. So our decisions need to be really selfless. We need to think very carefully when we make our decisions in terms of protecting ourselves, protecting our families. And I think that you shouldn't wait until you get COVID before you make lifestyle changes.
Yes.
That's the most important thing for me personally. And then I think also that whether you are suffering from COVID in terms of the acute illness or long COVID, it's important to remain positive. And it's important to also pace yourself, do not overexert yourself, take it day by day, take it step by step. And then do consult early if you have problems and if you have symptoms. Yeah.
Thanks, Dr. Titus. Dr. Amahulu?
I think everything's been said. I just want to give a big thank you to the countless number of Namibians who individually and corporately, in terms of corporate Namibia, that have come in solidarity to hold hands with frontline workers. We've had amazing teams coming to cook for us, bringing soup, oh my God, gorgeous soup, drinks, Energade, just the Namibian Chamber of Commerce, oxygen, bringing in extra bulk oxygen into the country. I'm getting emotional. It has gone a long way. It has alleviated huge concerns. It's a load off my shoulders as a hospital administrator to know that the desperately needed oxygen that we needed to come in country has been supplemented by these private donors individually and corporately. And I just want to say thank you to all of you. Your assistance, your giving is psychotherapy to us. It's that extra oomph that tells us we're doing our best, we are being seen, it's being recognized, and it enables us to do that extra, do what we can to save as many lives as we can. So to the Namibians out there who are giving, I mean, they're fixing beds for us, they are feeding us. I'm emotional when I think about it. I just want to say I love you on behalf of the Ministry of Health and Social Services. We love you, and we'll continue to do our best. So thank you so much. Get vaccinated, please, I beg you. Yeah.
So it is a labor of love, and that's the name of this campaign. It's that love protects. Dr. Kashitai talked about protecting healthcare workers and listening to the healthcare workers who are on the front lines, not dentists and vets and people who have not treated a single COVID patient. Listen to the people who are in the wards, to the cardiologists, to the neurologists, to the specialist physicians, to the likes of Dr. Marulu, obstetrician and gynecologist, to the likes of Dr. Titus, who's in the ICU wards. And I also just want to extend the same love to you that you are extending to this nation on a daily basis. And not only are you saving lives during the day, you dedicate your time that you haven't seen your families all day to educate our people about what's right and what's not right, And just the last message that I have is really that it feels like we're powerless against this invisible virus. But what these doctors are saying, we're not as powerless as we think. There's a lot that we can do, but there's also a lot that we're doing that's causing us harm. And we must listen to the science, we must listen to the experts, and not do things that make us end up in ICU wards where it could have been preventable. So love does indeed protect, and thank you very much, and thank you, Blanche, for your exceptional work as well, and thank you to each one of these doctors sitting around here. We'll see you next week.
Yamitiseza lingusa nikelezo yakule luyeme hamoho haliye yofumana mipendo yalo na ya COVID-19 luisileleze wakakokwani kakatisabu tuku wa COVID-19 lupumbeka mane hamoho chwalo nikulila vahavolu na zazi nzazi vavasweli kunokula nikulobazwa mwasipatela kavakala kokwani ka COVID-19 misilelezo fela yeliteni kikuluna kuswalana mazoho kuyema hamoho nikuya kwali vakako vasweli kunofa mipendo yesileleza vatukoka kokwani ka COVID-19 muvili wa mina hase ufumani mupendo wa COVID-19 uitukiseza kulwanisa kakokwani kale nako kaufela eka kakena mwa muvili wa mina hape umisileleza kuli musike mwakula kuyofitafa maye mwakulise mtotoveza hulu kwa tasi minilisupo za COVID-19 zemukava nizona kizenyenyani fera hakuswani inge mutu yasikafumana mipendo kikafoni misusuweza kuli hali ye luyeme luyofumana mipendo ya luna musike mwateleza likelezo kwa vatu baba sinaliseli kwa mana nizamiliani mutu yemukona kufumana kelezo kuyena king'aka wa mina kwa spatela ilivona veluviza mwasiku wakuli kima doctors kivona baba kona kumifa vuniti wakuli kimupendo manyi omuswanyala kuunga kava kalama tuku amangwe munaniona mwa muvili wa mina kikafoni misusuweza kuli haliye luyeme hamo luyofumana mipendo ya luna ya COVID-19 lupili sesi chava saluna mane hamo chwalo nikulipili saluna bai nani latelezi mwa mautu ababangu nenizofumana waka mpendo kusialezi fera kuli niyonga wa maferelezo kikachwalo ni misusuweza kuli haliye luyonga mipendo ya luna #do your part.